Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and how you can escape the collapsing U.S. healthcare system. Most of the guys that come see me have already been diagnosed with low testosterone by another provider, and the vast majority of them have already been put on therapy. And they come and see me because either they're not happy with their protocol or they want to sort of take their health to the next level. They've corrected their low testosterone symptoms, but now they've got other issues that they want to work on. But one of the questions that I always ask these guys when they come in already on testosterone therapy is, did your doctor ever tell you why you have low testosterone? And invariably the answer is no. I can only think of a small handful of guys that had their physician or their provider actually give them a diagnosis and tell them this is the reason you have low testosterone. Most of them are like, well, I never mentioned that before. And I think that's really important. I give credit to docs who make the diagnosis of hypogonadism or suboptimal testosterone and start therapy and do it properly. But it is extremely important, in my opinion, that as a physician, if you're going to start a man on testosterone therapy, that you have done your due diligence and done a proper workup for why that man has suboptimal testosterone. And again, I think most providers do this. They just may not convey it to the patient, but it's important to have that discussion because buried in the long list of things that can cause low testosterone are some potentially really serious medical conditions that if you don't think about those and you don't do the proper workup, send off the appropriate tests, you're going to miss that. And if you miss it, it may be years before it's picked up by somebody else. So, I think it's important. And so that's what I want to talk with you guys about today. There's two broad classes of hypogonadism. One is primary and one is secondary. Today we're going to focus on secondary, but let me mention primary briefly. Primary is very simple. It's end organ dysfunction. So something has happened to the testicle. It can no longer produce adequate amounts of testosterone. A lot of times it's trauma, maybe it's partially age related. Maybe you've had surgery, testicular cancer, radiation to that area. Who knows? Whatever the cause may be, the factory is closed. And so it doesn't matter how strong the signal from the hypothalamus and pituitary gland is, the factory is shut down and it's not reopening. So that's primary. That's the minority of men, by the way. And a lot of times, the primary hypogonadism, it's usually pretty obvious that either in the history or the patient will just tell you that they've had some sort of an issue with their testicles. So we're not going to talk about that today. So the focus today is going to be on secondary hypogonadism, or they sometimes call it central hypogonadism. And I'm going to go through a flowchart with you guys. Now, this one is from International Journal of Molecular Sciences. This is a 2021 article, so it's relatively new. It's called Treatment of Men with Central Hypogonadism, Alternatives for Testosterone Replacement Therapy. And so we're not going to talk about alternatives to testosterone therapy very much, but I show you the article because I screenshotted one of the little flow sheets in here that I thought was really useful. And I'm going to show that to you guys right now up here on the screen. So, and this is how my mind works too when I think of this problem, this issue of central hypogonadism, or I call it secondary because that's just how I was trained. So you can see here, you have two broad categories, organic and functional. So let's touch on organic just briefly. Organic just means, there's something structurally wrong, either something congenital that you were born with or something that was acquired later in life. And so we're going to talk about those in a little bit of detail here. So let's talk about congenital. So CHH, congenital hypogonadotropic hypogonadism. So these are genetic conditions where a child is born with one or more mutations that essentially prevents them from generating gonadotropin releasing hormone. Now these kids, a lot of times they'll be kind of small for their age, and many times they don't get picked up until very early adolescence because all their peers all of a sudden are going into puberty. These kids don't go into puberty. They're unable to develop the LH and FSH surge that needs to happen to initiate puberty because above that there's no cells there that, or they're dysfunctional, or perhaps they lack an enzyme to make GnRH. So I don't think I've ever seen one of these. I had a classmate once in high school that I suspect in retrospect, may have had this condition, but I have no way of knowing that. But these do show up on my boards periodically. Patients with this condition, or this constellation of conditions, they need to be expertly managed by an endocrinologist who's very familiar with these conditions. So there's two kinds. The first one is Kallman syndrome. Again, I've never seen Kallman syndrome. The hallmark of Kallman syndrome, in addition to the inability to produce GnRH and lack of development of normal puberty, is they don't have a sense of smell. And that's something that in my board exams, I always love to do that, is they'll mention the sense of smell. And then there's all these other variations of CHH, so normosmic, which just means they have a normal sense of smell. Again, these are ultra rare, and I personally have never seen one. I've never managed anybody that had one of these conditions. These folks see endocrinologists usually starting in very early adolescence, because that's typically where they get picked up. But the next one, under congenital, this is really important: hereditary hemochromatosis. This is extremely common in men. It exists in women too. Obviously, it's an autosomal dominant condition. I believe there's 4 different genes, 2 of which are the most common, that lead to this condition of hereditary hemochromatosis, which is essentially congenital or hereditary iron overload. Their bodies absorb iron excessively from the diet, and it builds up in a number of different tissues. The liver gets a lot of attention in providers, or with providers that manage hemochromatosis, but really it involves the joints, the testicles, and it actually involves the hypothalamus and the pituitary gland. So as iron begins to deposit, it is toxic to the local tissues and the cells in there. So in significant iron overload, you can actually see iron deposits in the hypothalamus and in the pituitary gland on an MRI scan. And so that's something that many endocrinologists will order. I've never actually done that, although I have personally picked up probably about a dozen cases of hemochromatosis in my career that were missed. It's extremely common. If you are of Northern European, especially Northwestern European ancestry, I've seen values of somewhere between 1 in 300 to 1 in 200 people carry one or more of these genes. So it's out there, and it's out there to such a degree that I have my eye out for it all the time. So the important thing about this one, if you've damaged your pituitary gland or your hypothalamus for that matter, with these iron deposits, a lot of times that's permanent. There's no going back from that. There are some case studies, and maybe a few instances in the literature where long-term phlebotomy, where they really get their ferritin levels down for a long period of time, they maybe recover some hypothalamic and pituitary function, but for the most part, you're not going to be making much LH and FSH anymore if this condition goes untreated for a long period of time. And that's important because men with this condition, so they don't respond to Clomid. Clomid makes your pituitary gland pump out LH and FSH, but you have to have a healthy pituitary gland to do that in the first place, and these men many times do not. So it's a big mistake. I've seen this one time where a patient like this was treated with Clomid, and naturally they didn't do very well on it. They got essentially no response. So these guys, they need to be on testosterone replacement many times, and or HCG if they want to maintain fertility. Unfortunately, there's not great options for them. The vast majority of these men end up on testosterone replacement because they're not picked up until much later in life, like in their 50s or later. At that point, fertility is not an issue for them, so many times they just end up on testosterone therapy. So very important. All right, down to acquired. Acquired. So these are men that have had direct trauma or injury to the hypothalamus, or to the pituitary gland. So maybe they've had a tumor that was resected. Maybe they had radiation therapy because of either malignant or benign brain tumor. The most common one, though, that I have seen over the years is trauma. So repeated traumatic brain injuries, particularly in military veterans, guys that have been in 5, 10, 12 different IED blasts. I know multiple guys like that who have been blown up on more than one occasion and suffered significant TBIs as a result of that. And unfortunately, these guys kind of fall through the radar. I don't know that the VA necessarily picks that up as well as they should, but direct trauma to those particular structures. And again, you're not getting that back. Clomid again is not a good option for these guys. They generally need to be on testosterone or HCG. Okay, so that's the organic ones. We're not going to talk about those anymore. Functional. This is where the vast majority of guys with low testosterone out there in the world, especially the ones that I see, this is where their issues reside. So the first one, I don't see this very much because most of the guys that come see me are pretty squared away, and they're not on chronic opiate therapy. They're not on chronic glucocorticoids, which is different than anabolic steroids, so cortisone, etc. Some of them have used or abused anabolic steroids in the past, and so they have suppressed their LH and FSH in some cases permanently by long-term use, and so that can sometimes be an issue. But in general, I don't see much drug-induced in my particular practice, but out there in the world, there's a lot of people hooked on opiates, either illicit opiates or they're on opiates for legitimate reasons that have low testosterone. And unfortunately, I don't think they get screened enough, or they don't get picked up enough by the primary care world, at least like I think they should be. So. The other one on drug-induced, so I made some changes to this little thing here, EDC. So these are endocrine-disrupting compounds. I've done podcasts and lectures on this before. There are a whole host of endocrine-disrupting compounds from industry that are now ubiquitous. They're in our food, they're in our water, they're everywhere, that are known to disrupt the endocrine system. They're known to interfere with testosterone production, both in the CNS, central nervous system, and at the testicle. It's a huge problem. It's probably the most one along with obesity that we'll talk about here in a second. Those are probably the two big ones that cause most of the what we call idiopathic hypogonadism, and is probably responsible for this trend in low testosterone that we're seeing over the last few decades. They didn't mention it in our article, so I put that in there. EDCs, something to think about. Very tough to avoid. There are things you can do. I've got another talk on that if you want to check that out. But man, it's almost impossible to completely eliminate these from your body. They're everywhere. All right, next one's Cushing's disease. So this would be Cushing syndrome or Cushing disease, whatever. Hypercortisolemia. Again, I don't see very much of this. This is usually from an adrenal issue, adrenal adenoma. These hopefully are picked up in your primary care clinic, internal medicine, family medicine, and then referred to endocrinology for treatment. Now, hyperprolactinemia, these, again, not common, but I have picked up a few of these little microadenomas. So these are little, they're benign, they're not cancerous, but they definitely can cause issues. Little growths in the pituitary gland themselves that have freed themselves from the negative feedback regulation in the CNS, and they start producing prolactin, which is a very important hormone. However, prolactin can cause low testosterone. And so a lot of times these things are pretty small. You can pick them up many times on an MRI. And when they're really small, you can treat these medically. I'm not going to go into that right now. Sometimes they get big and they need to be treated with surgery. If you don't treat them, they get very big. They can actually cause you to have blindness because they start pushing on the optic chiasm, and a neurosurgeon needs to go in and address that. So now, the next one, obesity. Guys, far and away, this is, again, along with EDCs, I really think they work together. It's kind of a chicken and egg phenomenon, but obesity by far is the most common cause of hypogonadism that I see out in the general public. And there's something in here that I wrote, it's called MOSH, M-O-S-H, morbid obesity secondary hypogonadism. Obesity is bad for you in ways that I just can't even go into in this talk, but one of the things that it does is it causes this pro-inflammatory state within the hypothalamus. And so you have men that have they have low testosterone. But if you had a healthy central nervous system, your body would detect that and it would start cranking out LH and FSH in many cases to compensate for that, right? The signal would get stronger. Well, in men with obesity, and particularly MOSH, they have low testosterone, but they tend to have low or inappropriately normal LH and FSH. The obesity itself is preventing the upregulation or the increased production of LH and FSH, and it's extremely common. That's probably the most common form of low testosterone that I see. And it's important to state too, you don't need to be morbidly obese. Like this is morbid obesity second. You don't have to be morbidly obese, okay? You don't have to have a BMI over 30. You can have just excessive adiposity. You can have a high body fat percentage. And remember, if you're 25% or above, you're obese. But you don't even need to be that necessarily to have that impact your testosterone levels. So super important. The good thing about that, if there's a silver lining to any of this, is weight loss can restore or greatly improve, I should say, your testosterone levels. You can get those LH and FSH signals back up again if you put in the work and lose the weight. Sadly, most people are just not willing to do that. Okay. Now the last one here, late onset hypogonadism. This is kind of a combination problem. They talk about obesity, comorbidities, and aging. Now, this is an interesting caveat about aging. It's debatable whether aging in and of itself has a massive impact on testosterone. Now, we know that as men get older, their testosterone levels drop. That's, I don't think that's debatable. But I've seen and heard very smart endocrinologists, andrologists, and urologists say that decline that we see with age is really not as so much an age-related phenomenon as it is the accumulation of various other comorbidities. Obesity, insulin resistance, a hyperinflammatory state, a number of other comorbidities that could potentially be influencing testosterone. So, I don't want to wade into that argument, but I think that there's something to that. So anyway, this is the little flow sheet that I mentally go through when I see somebody for the first time who has been diagnosed with low testosterone, or if I make that diagnosis. And I think it's really important that you guys know about this too. I know it's a bit medical, but one of the things on this channel that I don't want to do, that I think a lot of medical channels do, is dumb things down a little bit. I don't want to dumb things down for you. I know you guys are smart, so I think it's you guys should know. You don't have to know everything your doctor knows, but you should kind of get an idea of what they're thinking about in broad strokes. And this is what I think about when I see a guy with low testosterone that I know doesn't have primary, because I don't want to miss a prolactinoma. All right. Okay. I don't want to miss a pituitary adenoma of any kind. I don't want to miss hereditary hemochromatosis. I don't want to miss anything serious like this, a Kallman syndrome, which, I doubt I'll ever see that. But there's a few things out there that are important. I mean, hemochromatosis, if it's not diagnosed and treated, it's devastating. It's a devastating disease. You guys can look it up and read about it if you want to learn more about that. But it needs to be picked up. It needs to be picked up, and if it's treated aggressively, again, mostly with phlebotomy, guys do great. They do great if they can keep their ferritin levels down, keep their transferrin saturations down. They tend to do pretty well. So that's all I have for you guys today. Again, if you are on testosterone, if you've been diagnosed with low testosterone, and your doctor hasn't told you why you have low testosterone, maybe on your next visit say, "Hey doc, I forgot to ask you this. Why do you think I have low testosterone?" See what they have to say. All right, guys, that's all I got for you. I'll catch you next time. All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.